Coagulation Studies, PT, PTT, INR, mixing. Welcome to today's podcast, where we'll be delving into a fundamental topic in clinical medicine, the study of blood coagulation. Our goal is to break down the concepts of prothrombin time, international normalized ratio, and partial thromboplastin time in a structured and comprehensive manner. Let's explore not only what these tests are, but also why they matter so much in everyday medical practice. To begin, let's clarify the essentials. The prothrombin time and international normalized ratio, along with partial thromboplastin time, are critical blood tests that measure how efficiently the body forms blood clots. These tests evaluate two major pathways within the coagulation system. The prothrombin time and international normalized ratio primarily assess the extrinsic pathway and the common pathway, focusing especially on clotting factors produced by the liver. These tests are frequently used to monitor therapy with medications such as warfarin, more commonly known as Coumadin. The partial thromboplastin time, on the other hand, is designed to evaluate the intrinsic and common pathways. This test is invaluable for monitoring therapy with heparin, screening for hereditary conditions like hemophilia, and identifying specific deficiencies in clotting factors. Why do clinicians order these tests? There are several important reasons. One is to evaluate the risk of bleeding, for example prior to surgery or in patients presenting with unexplained bruising or bleeding. Another is to monitor anticoagulant therapy, whether a patient is on warfarin or heparin. These tests help ensure that treatment is both safe and effective. They are also used to assess liver function, since the liver produces most of the body's clotting factors, and to diagnose specific bleeding disorders such as hemophilia or von Willebrand disease. Let's move deeper into the details of how these tests are performed and interpreted. The prothrombin time and international normalized ratio measure the extrinsic and common clotting pathways, focusing on factors such as factor 7, factor 10, factor 5, prothrombin, and fibrinogen. In the laboratory, a tissue factor is added to a blood sample, triggering the extrinsic pathway, and the time needed to form a clot is measured. The international normalized ratio was developed to standardize prothrombin time reporting across different laboratories, especially for monitoring warfarin therapy. The International Sensitivity Index is specific to each laboratory's reagent and is used in calculating the international normalized ratio. When the prothrombin time or international normalized ratio is prolonged, it means there is impairment in the extrinsic or common pathway. Common causes of this include warfarin therapy, since warfarin is a vitamin K antagonist that blocks synthesis of several clotting factors. Factor 7, which has the shortest half-life, is affected first, so the prothrombin time and international normalized ratio rise quickly. Liver disease can also prolong both the prothrombin time and partial thromboplastin time, as the liver is responsible for producing nearly all the clotting factors. Vitamin K deficiency, often seen in cases of malnutrition, malabsorption, or in newborns, can also prolong these tests. Other causes include disseminated intravascular coagulation, which is characterized by widespread clotting that exhausts clotting factors, and specific deficiencies of factors such as factor 2, 5, 7, or 10 in clinical practice. The typical goals for the international normalized ratio are as follows. A normal value ranges from about 0.9 to 1.1. For patients taking warfarin to treat conditions such as atrial fibrillation or deep vein thrombosis, the target range is usually between 2.0 and 3.0. For those with mechanical heart valves, the range is often set higher, between 2.5 and 3.5. Turning to the partial thromboplastin time, this test measures the intrinsic and common pathways, looking at factors including factor 12, 11, 9, 8, 10, 5, prothrombin, and fibrinogen. The laboratory procedure involves adding a surface activator and phospholipids to the blood sample, which activates the intrinsic pathway. The activated version of the test is even more sensitive and is widely used in medical laboratories. A prolonged partial thromboplastin time indicates an impairment in the intrinsic or common pathway. Common causes include therapy with unfractionated heparin, which boosts the effect of antithrombin and inactivates both thrombin and factor 10A. Hereditary bleeding disorders such as hemophilia A and hemophilia B, caused by deficiencies in factor 8 and factor 9, respectively, are classic examples. Von Willebrand disease, the most common inherited bleeding disorder, also leads to a prolonged partial thromboplastin time because von Willebrand factor stabilizes factor 8. Other causes include lupus anticoagulant, which is actually a prothrombotic antibody that interferes with the test and causes prolonged times. Liver disease, the presence of antibodies that inhibit specific clotting factors, and disseminated intravascular coagulation. For patients on heparin therapy, the clinical goal is usually for the partial thromboplastin time to be about 1.5 to 2.5 times the normal value. In real-world clinical practice, how do we interpret a full coagulation panel? Here's a logical approach. If the prothrombin time and international normalized ratio are normal but the partial thromboplastin time is prolonged, the problem likely lies within the intrinsic pathway. Typical causes include heparin therapy, hemophilia A or B, von Willebrand disease, deficiencies in factor 11 or 12, or the presence of lupus anticoagulant. If the prothrombin time and international normalized ratio are prolonged but the partial thromboplastin time is normal, the issue is probably in the extrinsic pathway, such as early warfarin use, factor 7 deficiency, or mild vitamin K deficiency or liver disease. If both are prolonged, this suggests a problem in the common pathway or multiple pathways, such as severe liver disease, disseminated intravascular coagulation, severe vitamin K deficiency, fully therapeutic warfarin use, or deficiencies in factor 10, 5, prothrombin, or fibrinogen. If both values are normal, the coagulation pathways are intact, though this does not rule out platelet disorders or mild von Willebrand disease. In these cases, additional tests like bleeding time or platelet function assays may be necessary. It's important to recognize the limitations of these tests. They are screening tools, designed to identify the presence of a problem, but not always its exact cause. When a prothrombin time or partial thromboplastin time is prolonged, mixing studies with normal plasma can help clarify the situation. If the abnormal result corrects with mixing, it suggests a deficiency in one or more factors. If it does not, it points to the presence of an inhibitor, such as heparin, a specific factor antibody, or lupus anticoagulant. Importantly, these tests do not assess platelet function, blood vessel integrity, or fibrinolysis. As a result, patients may still have significant bleeding disorders, such as von Willebrand disease or platelet dysfunction, even if their prothrombin time and partial thromboplastin time are normal. Another test worth mentioning is the thrombin time. This less common laboratory test measures the final step in the coagulation process, the conversion of fibrinogen to fibrin. It is particularly sensitive to the presence of heparin and low fibrinogen levels, and is often used to confirm heparin contamination. In summary, the prothrombin time, international normalized ratio, and partial thromboplastin time are indispensable tools in clinical practice. They provide a rapid and cost-effective snapshot of the coagulation system, inform therapy with anticoagulant medications, help screen for surgical risk, and serve as the first step in diagnosing complex bleeding disorders. Correct interpretation requires a solid understanding of the pathways these tests measure and a systematic approach to any abnormalities that arise. Thank you for tuning into today's episode. If you enjoy the content, please like, share and subscribe. It's the Everything Surgery Podcast. Dissect the Extraordinary.